you very much. I'm very pleased to be here with you, and honored for the invitation. I would like to speak. Sorry for the. I didn't know that it was in English. I would like to speak for a very pleasant 87 years old man, very sick, very fragile, and with previous medical history with AF. Very severe peripheral disease with neuropathy because of the alcohol, anemia, kidney heart failure with the clearance of the creatinine 15 ml per minute, very high, severe heart failure with NIHA 3 and proBNP very high. Severe aortic stenosis with the Euroscore 1 62.41 and the Euroscore 2 26.7. At the echoes, we can see that we have a reduced, moderately reduced ejection fractions with RSVP 55 to 60 with a very severe aortic stenosis with 0.4 centimeters square and a maximum AV 5 meters per second. We did a coronary angiography, so we cannot see a severe coronary disease, and we proceed to the three-dimensional analysis, and we decide to proceed the procedure with the TAVI with the 34 millimeter Evolut Pro Plus. As we can see, the high of the coronary ostium orifice are good. We can see that the dimensions of the peripheral vessels are very good, and as we saw is that we have actually a rough between the right and the left coronary, those are the peripheral arteries that the dimensions, and they're not very calcified. Actually, they're very good. And we start the procedure with the balloon predilatation with the balloon 23. As you can see, previous, we had, this one is previous, before the predilatation, sorry about that. We have at least moderate regurgitation. We did the predilatation with the balloon 23, and after that we proceed to the at the cusp overlap section. As you can see, we released the valve because at the cusp overlap we didn't saw anything weird to happen. But as you can see, to the three cusp overlap, we saw that there is an enfolding of the valve. Actually, we didn't see from the beginning that it was enfolding, but we saw it after we released the valve. And the most important thing is that we had an entrap of the cone of the delivery system. We cannot pull out the delivery system. As you can see here, there is the line that is very typical for the enfolding, in case of enfolding valve. This is the line and the Pacman saw that we can see most of the times at the enfolding, and this is the mechanism of the enfolding valve. This is another photos, not for our cases, because we are not very likely to take it out and change the valve or resist the valve. But after that, because we didn't want to insert the second sheath, a large sheath, sheath, sorry, we insert the second wire as a safari wire, and over the wire we did balloon inflation with a small balloon through the 6 French sheath that we have in the left coronary, femoral artery. But the scope of this procedure was to change the anatomy of the enfolding struts so we can pull out the delivery system if we were lucky, but we didn't. We weren't so lucky, and we put after that, a 12 French sheath from the left femoral artery, and we did after that the post-dilatation. As you can see, after the post-dilatation with the 25 balloon, there is a recoil of the stretch of the valve. The final result, as we can see at the right, this one, it's quite good, as I can see. There is a mild PVR, but we don't have any gradient. So we were very pleased about that. Here you can see the two sheaths. The first one, 18th French sheath from the right femoral artery, and the second one, it's a 12, not a 14, sorry. This is the second day triplex that you can see. As you can see, there is not severe PVR, and the AV max was 2.2. So the results, I think it was good enough after what happened. And for the conclusion, the stent frame enfolding of self-expanding valves is it's very rare. More, as you said before, the frequently described with the large valves, 29th and most of them 34. The mechanism is still unclear, but we can say that is very often the improper valve loading or the reseating valve, most of the times with very calcified valve, very elliptic or bicuspid aortic annulus, and not properly predilatation. The complication could lead at severe PVR or regurgitation, or as you saw to our case, entrapment of the delivery system, which is very unrare, and I didn't saw anything like that before. Thank you very much.
Congratulations for the very difficult case and for the result, Dr. Psathas. It's the second case today with enfolding, so it is not so rare. Because of the time, there will be only one comment. Perhaps Professor Tsigas, he's with us.
Yes. Okay, congratulations again. I don't agree that it's very common to see enfolding with this type of valves, but of course are always interesting to discuss. Elliptical shape or non-symmetrical or asymmetrical shape is always a characteristic that guides us to choose a self-expanding valve because of the shape of the anatomy. And at least based on the data we have to prefer this kind of valves. And of course, Evolut is the best choice, I believe, until now. And balloon expandable valves is something that we still learn how they behave in this anatomy. Edwards of course, has data to persuade us that we can use in this demanding environment. Congratulate again for this result.
Thank you.
Okay, Dr. Sparias.
The elephant in the room in this case was your successful passing of the wire through the valve to do the valvuloplasty.
It wasn't very easy.
I would like to stress this because everything was done perfectly, and for me, the most difficult part of this procedure will be to pass the wire correctly through the valve to do the valvuloplasty, because it will be very easy to go through a strut down, and then it will be a disaster because you would completely deform this valve. And so congratulations. And for other users, when you have a case like this, you should be very careful and always confirm that you're through the valve. What we're usually doing, we're taking a balloon, a valvuloplasty balloon 20, 23, we just prepare it, so we inflate it and then we deflate it so it attains a larger profile, and we just go through over the wire to make sure that it goes through easily, because if it goes through a cell of the valve, you feel resistance and you know you're wrong, so you stop. Thank you.
Thank you.
Dr. Kilic.
Thank you very much for the nice presentation. And one of the mechanisms for stent enfolding is asymmetric deployment of the valve. This is very important, and rapid facing failure, sometimes movement during implantation, can be cause of stent enfolding. This case, for example, for the last phase that you release the valve, I think it should be better to control to the left anterior oblique caudal weave before releasing the valve during the cusp overlap technique. This is another mechanism to be kept in mind. And if you feel also resistance during insertion in the delivery sheet, this is another warning sign for stent enfolding, especially in very calcific peripheral arteries. When you insert the valve inside the sheet, this is another warning sign to be kept in mind. Thank you.
Thank you.
Okay, thank you, Dr. Kilic. Thank you, Dr. Psathas. Congratulations again.